Good morning. Hi, everybody. We'll start in 2 minutes. If you can scan this QR code to log in, that would be great. Hi, if you can scan this QR code, that would be great. My name's Natasha. We'll start in 1 minute.
이거 어떻게 한다는 거야, 이거는? QR code login for path to. 아씨, 또 뭐야? 올라갔다 봐야겠네. 씨.
Okay, it's 9:45, so we can start. How is everybody? You might be muted, so.
Pretty good. Hello.
Good. Okay, great. Here, let me, oh, there's a chat. Perfect. Okay, I am going to remove this screen share for right now. So you guys finished your first week. Have any of you guys started your second week yet? You will today. Okay, cool. So if you want to go over the first week, we can. If you guys have any questions specifically, you can ask me, or I can just lecture what I wrote down for my first week, whatever you guys prefer. So just let me know. And I'm Natasha. And did you guys sign in? Yes, sign in, please. Let me see if I can get the link real fast too. Okay, let's see. Let's see. I sent the link to myself. Okay, let me see. Perfect. Okay, I got it. All right, I'll post it in the chat and just fill out the form. Yes, I removed the barcode. I can put it back on, but but the link works as well. So there's the barcode. You can scan with your phone and it will take you directly to the link. And then just let me know when you guys are done with that. Let me see. It's like a different format this time. Okay. I think I gotta stop sharing. Okay. Yes, or you can click this link. And so just let me know when you guys are finished with that, and then we can start. Okay, perfect, Sam. Do you see a link in the chat bot? Oops, it's a private, sorry. Here, there, do you see the link right there? Okay, perfect. Here's the link if you want to sign in. That's your student ID number. So you can access that on your portal. If you go under your academics and my information, you'll see your student ID number. Perfect, thank you. I'm glad you guys are all here today. And if you get a chance, I would go to the NCLEX workshops as well. They really help a lot. So I think, Anastasia, did you sign in? Okay, perfect. And owner, I don't know if that's your name or not, but if you could sign in, that would be great. Okay, so do you guys want me to lecture, or do you guys have specific questions?
I have a question. I type it down for you about the infection control.
Okay, so since we're in the hospital, that's what we're focusing on for infection control. But in the home, we do teach patients how to use, aseptic technique and stuff to clean wounds, etc., and how they can prevent infection. But in the hospital, there's contact, droplet, and airborne precautions, and that requires different PPE for depending on the patient and what precautions they have. Does that answer your question? Okay, perfect. Yeah, of course. So yeah, if you guys have any specific questions, please let me know, or I can start lecturing off of.
I'm sorry for interrupting you. Just one more question. You said that we also have to go to other tutoring or workshop?
They have an NCLEX tutor that's available. His name's
Bernie.
Yeah, I totally recommend it because it really helped me in funds. Okay, it's at 1 p.m. Great, yeah. And I think he does multiple days.
Can you tell us what was your professor before?
Oh, I had Professor De Salinas. She is not here this term, but I will help you guys as much as I can.
Thank you so much.
Yeah. And who are your guys' professors? Garcia, okay. Garcia, Reyes, Baltazar. Okay. Perfect. All right. Well, any more questions, or do you guys want me to just start lecturing on my week 1? Okay, perfect. Okay, so, and you guys read the book and read the fundamentals book and practice the questions is what I recommend for everybody. Your midterm will be here before you know it, so don't get behind. And so, okay. So vital signs, do you guys know what the vital signs are? Yes, okay. Do you want to tell me them or tell the other people what the vital signs are? Baseline of the normal range for the patient. Baseline is, yeah, like, so when the patient comes in and their average, temperature, heart rate, that's their baseline. So if it differs a lot, something is going on. But there is, normal rates for all of us as well. And so the vital signs, there's heart rate, yes, blood pressure, pulse, temperature, pain, O2 sat. So there's heart rate, respiratory rate, blood pressure, temperature, and pain. And what is the normal heart rate? Yeah, 60 to 100, great. And what is the normal respiratory? Sorry for the noise. Close the window. Okay. Yeah, 12 to 20, great. And what is the normal blood pressure? Yeah, O2, 95 to 100, that's great. Yeah, 120 over 80. And temperature, what's the average temperature for somebody? 98.6, perfect. And pain, we can assess pain by different scales. And what is one that we commonly use? Yeah, the pain scale from 0 to 10, 0 being the least amount of pain, 10 being the most excruciating pain you could be in. And so that one, and you always want to listen to the patient when they tell you their pain level, because that is the most accurate indication of pain, because they're telling us what their pain level is. Culturally, some may minimize the pain that they're in, but we just have to go by what they tell us. And so the heart rate, to assess the heart rate, the peripheral pulses, how do we assess that? Do we do it at the same time? And when do we not use 2 fingers, like, to assess the heart rate? Yeah, so there's different pulses. There's popliteal pulses, there's pedal pulses, the radial pulse. And if you notice a difference between the bilateral pulses, then you assess the apical. And how long do you assess the apical for if that happens? 1 full minute, yes, exactly.
Okay. What does it mean bilateral? I already forget.
Bilateral, that just means like you assess them at the same time. So when you have the radial pulses, you put your 2 fingers and make sure they're even. And if they differ, so carotid is not bilateral because it's dangerous to assess both because the blood's going to the brain. So there we only use one hand. And then so the heart rate, 60 to 100, what is it called when it's lower than 60? Do you guys remember? Yeah, bradycardia. Perfect. And when it's above 100, what do we call that? Tachycardia. Right, exactly. So we use a scale of 0 to 4 to note the beats per minute. And so 0 means absent. So you don't hear a beat or a pulse. And 1 plus is a weak pulse. +2 is normal. +3 is increased, and +4 is bounding. So just remember the carotid artery, you just do one side independently. And with these pulses, you can feel for 30 seconds multiply by 2. And if there's any difference, assess the apical pulse for 1 full minute using this stethoscope. Repeat the, which one? The 0 to 4? Okay, so 0 means absent. +1 is weak. +2 is normal. +3 is increased. And +4 is bounding. So that just means it's like pumping really hard where you can feel it a lot. It's not just like increase, but just like pumping really hard. Of course. Okay, so what can affect heart rate? Like what can raise the heart rate? Anxiety, yeah, anxiety can definitely raise the heart rate. Exercise, yes. And there's, yeah, coffee, perfect, caffeine. Awesome, awesome, you guys. Okay, so you ask the patient if they've had caffeine, exercise, if they've been ambulating, which means just walking around. You ask them how they're feeling. Are you having any symptoms? And for temperature, what do you want to make sure that they haven't done right before you took their temperature? Yeah, you want them to relax, but also if they've had anything to drink, like hot coffee, that can alter results. If they've had any food, if they've smoked within the past 30 minutes. So usually you want to wait 30 minutes after they've drinking, eaten, or smoked. And for respiratory rate, so what do we call the respiratory rate less than 12? It's similar to the heart rate, but a different suffix. Yeah, bradypnea, perfect. And higher than 20? Tachypnea, perfect. And what do we call when there's no breathing or absence of breathing? Sometimes people stop breathing in their sleep. What do we call that? Apnea, perfect. And when they stop in their sleep, it's sleep apnea. And so what do we call, let's see, when you have difficulty breathing laying down? Do you guys know what that's called? So that's called, so yes, it's close. It's orthopnea. So here, I'll type that into the chat.
Excuse me, Natasha. Do you know why my message are private? Oh, I don't know why. Privately. It says privately. Can you see my messages? It's Anastasia.
I can see your messages, but they're to everybody. The last one was exercise, age, anxiety, relax for 1 minute. Is that correct? If you click on the blue icon in the chat, it can message different people privately. And I am the WCU-LA PAL 2. Okay, perfect. I'm glad we figured that out. Okay, and then, okay, so respiratory rate. So orthopnea is difficulty breathing, laying down. And when you have a gasping, ineffective breathing, they call it, oops, or this is on the sheet, aginal. We weren't asked about that, but you know, it's always good to know. And what do you call difficulty breathing? Another word for having difficult breath. Yeah, perfect. Dyspnea. Okay, so blood pressure. Is it normal to have less than 120/80? Yes, perfect. Yeah, people exercise and can get their heart rate really low, and know the hypertension stages. Do you guys know the hypertension stages? Pre-hypertension. Yeah, 120 to 120. Well, it's actually what I have is 120 to 139 and 80/89. Yes. And then stage 1. So just remember, pre-hypertension, it goes all the way to 139, and then the rest of them count by nines, pretty much. So stage 1 is 140 to 159. Oh wait, they both, so the systolic is like you count 19 over, and then the diastolic, it's like 9 over. Okay. So, okay, so here, I'll type them in. So, okay, pre-hypertension is 120 to 139, and then 80 to 89, and then hypertension stage 1 is 140 to 159, and then 90 to 99, and then hypertension stage 2 is greater or equal to 160 or greater or equal to 100. And I'll give you guys a YouTube link also at whenever we're done. You can access this video on YouTube now, so that's great. Okay, and then for temperature, what's the word that means without fever? Does anybody know? So that's afebrile is without fever. So make sure you know that word, and always the root words really help with just figuring out what the word means. They have the same root words. Okay. Giselle, are you here twice? I just let you in again, and there's 2 of you. Okay. So, and then what can affect our vital signs? We already said caffeine, exercise. What else can affect our vital signs? Smoking, yes. And then illness, fever, and pain. Those can all increase our vital signs. So PQRST, do you guys remember learning about PQRST on how to assess pain? Like if somebody says, yes, I'm in pain. Yeah, so yeah, provoking, precipitating. So first you ask, are you having any pain? Yes. So provoking and precipitating factors, what provoke this pain, what brings it on, what makes it better, what makes it worse, the quality, what does it feel like, can you describe it, the throbbing, stabbing, dull, stinging, burning, the region and radiation. Is it radiating down the leg, If it's lower back pain radiating down the leg, it might be sciatica. Or if it is just in one local area. And then the severity, we can use the pain scale 1 to 10. If they're unable to speak, we can always use the Wong-Baker face scale. And with infants, you use the CRIES scale. And then the time in treatment, how long has it lasted? Is it intermittent? Does it come and go? Does it happen only when you're laying down? Is it only at night? And what are you taking, the treatment? What are you taking? Does the medicine help? And yeah, so the infant scale is the CRIES. I think it's spelled that way. Hold on one second. C-R-I-E. Oh yeah, it's just C-R-I-E-S. So it's crying. R is requires increased oxygen. I is increased vital signs. E is the expression, and S is sleeplessness.
Natasha, question, and how they do determine their CRIES pain from 0 to 2? So how that they multiply by 2? So I don't understand how they equivalent and range this crying.
You don't need to know it in detail. Just know that, you know, it's for infants. And so like crying, it has like 0 to 2. There's no cry is 0. 1 is a cry high pitched, but the baby is consolable. 2, the cry is high pitched, but baby is unconsolable. And then so it all goes from 0 to 2. So 2, 4, 6, 8, 10. So there's a total score of 10. And a further pain assessment should be taken if there's a score of 6 or higher. So 0 is pretty much no difference. They're not in pain. And then 2 is they're in pain. So they need a lot of oxygen, their heart rate or blood pressure is increased, they're grimacing, and there's a vocalization grunt, and the child has been awake constantly. And then there's also, so that pain scale is for infants, and there's also the FLAC scale, and that is used for children between 2 months and 7 years, or children unable to communicate their pain. Oh, perfect. Thank you. Thank you, Anastasia. I hope I'm saying your name right. Okay, and then, so the FLAC pain scale, FLACC. And so that is face, legs, activity, cry, consolability. And that also, is a scale to 10. And it's similar to the cries, but that's for a little bit older, when the infant, when the child doesn't need the oxygenation. Perfect. Thank you, Sam. Okay. So knowing the different pain scales was important for my quiz. So I suggest you just know what pain scale to use for different kinds of people, you know, if they're unable to speak or if they're able to speak, if they can describe it, if they're infants, or if they're young children. Somebody else is joining, so let me just, okay. So next, okay, hi Rima. If you can sign in, here's the link to sign in. If you can fill that out, that would be great. My name's Natasha. Okay, so we went over PQRST, and then what for pain management? Oh, somebody signed. You guys still hear me?
Yes. So yeah.
Somebody signed into the account, so I was just wondering. Okay, what was your question?
So my question is, do you know what scale, pain scales do we use for patients who can explain and able to explain, like children and adults? What kind of scale we have to know?
You can use a 0 to 10 scale, pain scale.
Do you mean the Ocher scale or Wong-Baker-Faces pain scale? Baker.
Wong-Baker-Faces is so it's just called the numeric rating scale.
Okay, so the pain scale from 0 to 10,
Yeah.
it's the numeric, right? Numeric rating pain scale. Okay, thank you so much.
Yes. Okay. Okay. And Rima, did you sign in?
No, I didn't sign in. Should I click the link?
Yes, please. If you could click the link and just fill it out, that would be great.
Sure, yeah.
Thank you so much.
Sure.
And then so what pain management can we take as nurses? What should we do first? Should we do most invasive or least invasive first? Yes, so the least invasive first, and some different types of least invasive interventions. We can use distraction, music, massage, visualization, and first it's good to just reposition the client, and that can help. Yeah, heat, cold, but repositioning is great because they could just be in pain because they've been on one side for too long. And we're supposed to reposition a client every 2 hours. And I don't know if your class talked about the different pain medications like NSAIDs. That an example of NSAIDs would be Motrin or ibuprofen, but the negative to those are gastrointestinal upset, gastric ulcers, or bleeding ulcers. And then we can use opioids, but the negative about those is that they're narcotics, they can be addictive, they can cause constipation and respiratory depression. So if we administer those, you know, we gotta keep an eye on the breathing, bowel movements, and just making sure that they really need them and there's not something else we can do that's less invasive to help their pain. And so we'll move on to communication. And so we always use therapeutic communication with our patients. And I'm sure you went over in lab as well as lecture, ISBAR. And do you guys remember what that means? Hold on, sorry. So you first introduce yourself, state your name, which unit you're in, ask the patient's name, and so like, hi, my name's Natasha. I'll be your nurse until 8 p.m. And I am a student at West Coast University under Dr. So-and-so. And you ask their name of date and date of birth. Oh, ISBAR, actually, this is for, I was confusing ADITH and ISBAR. Okay, so ISBAR is when you're handing off the patient to another nurse, or you're calling the doctor for a recommendation for medication or a different intervention that you think is appropriate for the patient. So you introduce yourself, so you like call them on the phone, or you're talking directly to the nurse and you say your name. Okay, this patient is in this ward, this unit, their age, sex, and the admitting doctor. And then you tell them the situation. You can, if you're calling, I'm calling about, and the reason for this call or referral, or if you're handing off the patient, so what's happening in the present moment. This patient is vomiting and hasn't had a bowel movement for 3 days. And then the background, the patient came in for nausea and constipation, if they have allergies, past falls, just vital signs. And then that's part of your assessment. And then your recommendation is, oh, would you like me to test their blood glucose levels, ABGs, whatever tests, or if the doctor prescribed medication, oh, I gave the patient medication 2 hours ago, they need medication in 1 hour. So it's just a communication we use for communicating with each other in the medical field. And for patients who speak a different language, and are we allowed to translate for them? Is their family allowed to translate for them? Okay, so no, the family isn't allowed to translate, and we're not allowed to translate for them. We have to have a certified translator. And some languages have different dialects, so we have to make sure that it's also in the patient's dialect, so there's no miscommunication. And when you're speaking with a translator, you want to face the patient and speak to them instead of face the translator, because it's more, therapeutic communication, speaking to the patient, and then the translator will translate to the patient. Does that make sense? It's not allowed for a family or yourself to translate. You need a certified translator. So, when you can't pronounce words, what is that called? Oh, sorry, my Zoom. So it's called dysphagia. Is when you can't pronounce words. So it's good to use visual aids and try to help the patient as much as you can. Just know the patients are number one priority, and we just want the best for them. So, okay. So I think that's all I have on communication on the first lecture. And then infection control. So infection control, I know that it's kind of confusing, but once you just get down the information and practice it, it really helps. So that's what I suggest, is just going over the different precautions, and because on your test guaranteed, they'll say what kind of precaution is, TB, or what kind of precaution is C. diff. So what is the most important thing to prevent infection? The number one thing. Yeah, hand hygiene. Perfect. That's great. So you hand hygiene before you see the patient, after you see the patient, gel in, gel out, and you use gloves whenever you're touching a patient. And then when do you use soap and water? Excuse me. I've had too much Red Bull. Yeah, so with contact, yes, perfect. Good job, Rima. So soap and water if your hands are visibly soiled with bodily fluids, blood, urine, sputum, ear drainage. C. diff, always soap and water because there's stool transmission. And we use warm water, 4 to 5 milliliters, and milliliters and cc's, they'll use them interchangeably. It's the same thing. It's the same unit. So 1 cc is 1 milliliter. So it's 4 to 5 milliliters or cc's is the size of a quarter. And then you just lather up and sing happy birthday 2 times, 15 to 20 seconds, and get your nails, your fingers, your wrists, and when you rinse, so you want to use 4 to 5 milliliters or cc's, but I was just saying that 1 cc is the equivalent to 1 milliliter. So like for conversions, if it says 4 to 5 cc's or 7 milliliters, you would pick 4 to 5 cc's. Does that make sense? Yeah. I don't think it will be that tricky, but it's just good to know that cc's equals milliliters. And then when you rinse, you put your hands downward and paper towel to dry the hands and also to turn the handle off. And then you can use hand sanitizer when there's no contact with the bodily fluids, the patient doesn't have C. diff, and your hands aren't visibly soiled. And so for when we put on our PPE, what order do we put it on? So putting on. So you put on your gown, and then mask. Yeah, perfect. And then goggles and face shield. And lastly, we put on gloves. Awesome. And yes, so when we were putting on our PPE, we first put on our gown, and it ties in the front or the back, depends. And then you put on your mask, and you want to try to not make it like aseptic technique. So, just put on the ears, and then the goggles and a face shield. And lastly, you put on your gloves. And so that's putting on the PPE. And how do we take off the PPE? It's a different order. So first is gloves, and you usually glove to glove, skin to skin is my notes. So you want to, you'll learn in your lab how to correctly take off gloves, especially if they're soiled or, not sterile anymore. So gloves, gown, then goggles, if you have them, and then your mask. And then you wash your hands. And there are videos on ATI where it shows the person taking the gloves and gown off at the same time. But for any test questions, when you're coming out, take off your gloves first. So that's always the answer. Gloves first is taking off. And gloves last, putting on. That's how I remembered it. Easier. Okay. And so there's infections that we can get in the hospital and they're pretty common, unfortunately. So that's why we use all the different PPE and sterile technique when we need to. And so what do we call the infections we get in the hospital? Does anybody know? So here, let me type it out. Yeah, the HAI, and then they also use this nosocomial. But HAI they'll use a lot too. Perfect. Good job, you guys. You guys are so smart. I think you'll do great on this test. Oh, okay, sorry. 2 more people were waiting. Sorry, I don't know how to remove the wait room, so I don't know how long you guys have been waiting, but I apologize. Here is the login code for those who just joined us. We are on infection control, and once we're done with this, we can go over whatever you guys want. So if you could just fill that out. My name's Natasha, and I'll be here every week. Okay, so so the HAIs, the healthcare associated infections, there's contact. So, okay, just click on the link. Do you see that link? You click on the link and then just fill out the form and ask for my name and ask for your student ID number. You can get it in your West Coast portal and under your information. Okay, so yeah, of course, thank you. Okay, contact precautions. So what do we need to wear for contact precautions? Yeah, gown and gloves and always mask. And so these can spread through contact. And so some of the different ones I can, I'll paste what I have for different, so C. diff, impetigo, herpes, encephalitis, I just put enceph, but encephalitis, tygo, hep A, lice, scabies, any dermatological contagious infections. So that's contact. And so I suggest just memorizing all of the different infections just in case, because you never know which one they're gonna ask you what is a contact precaution. But definitely C. diff, know that C. diff is always contact precaution, and you always have to wear gloves and wash your hands with soap and water with C. diff. And then droplet precautions. I was reading pertussin because that's a droplet precaution, but I was saying it at the same time. So pertussin, rubella, and mumps is a droplet precaution. And these are larger, and so like I think they're larger than 5. Let me see. Let me make sure. Droplet. Yeah, I think that's like, I'm not sure. I'll have to get back to you guys on that. Yeah, 5 microgram. I knew it was 5 something. So 5 microgram. So those are, droplet is larger. So if you imagine just like gravity, it will fall to the ground faster than airborne, which is smaller than a 5 microgram. And airborne, that is, and droplet, COVID is a droplet. Hi, Andrea or Andrea. Here is, oops, no, I don't have the code. Oh, here it is. So COVID is actually a droplet precaution. Here's the login on Andrea. And then also airborne, TB and varicella. So just know the TB and varicella are airborne. And those stay in the air longer. You want to use an N95 mask. And when you're transporting a patient that has a precaution in place, what do you always do? Yes, put a mask on the patient. Perfect. Awesome. Okay, so those were, yeah, cover. You don't necessarily need to cover the eyes, but nose and mouth with a mask, definitely. So yeah, so that is my lecture from week 1. I hope it aligns with yours. And then for any new people that joined, we can go over whatever you want. For the people who have been here since the start, if you have any other questions, please let me know.
Natasha,
Yeah.
can you clarify, please, what does it mean? Sam said, put the mask on the PT. PT is patient.
Patient, yeah, PT is patient. PT is patient. Let me look through infection control. Okay. So I'm just making sure that okay. So airborne is N95. You use eyes, nose, and mouth. Eyes, full face protection if there's a spraying possibility. And that has, yes, I can. And that has the negative pressure airflow. So airborne, remember negative pressure airflow as well. Now let me find the YouTube. So yes, everybody who just joined us, there's also a YouTube that has the whole lecture from the beginning. But we can go over whatever because I'm here for another hour. Okay. Here's the YouTube channel link. Oh. Hi, welcome. It's a negative pressure airflow. For those who just joined, if you can, there's no video yet because it's the first lecture, so they'll put it up, I'm sure, later today. I'm not in charge of putting it up, but for those who just joined us, please fill out the sign-in form. it will just ask your name, your ID number, and you can get that on your portal. And my name's Natasha. So any other questions? Definitely read your ATI book. The chapters aren't that long, and like mine, I have it highlighted and, you know, every chapter marked. And I like to read the ATI book and then the lecture book, so you kind of see what's similar, what goes, you know, hand in hand, and just from the infection chain. What do you mean infection chain? You're talking more about like micro?
Yeah, so I just meaning that do we need to know the sequence of infection agent, reservoir, portal of exit, right? I mean,
Yeah, well, that is on the ATI. So it's in the ATI book on page 53. So chain of infection, the causative agent is the bacteria, the virus, the parasite, fungus, prion, and then what we call the reservoir. Yeah, perfect. Thank you, Anastasia. So this can even be matter on inanimate surfaces. And okay, so the susceptible host, there's immunocompromised breaks in skins. This leaves the host more susceptible to infections. And also, when we talk about PPE, I'm going back to PPE really, really quick. So for people who are going through chemo or have immunocompromised systems such as HIV, you want to make sure that, I remember on ATI, they had a question about what shouldn't be allowed with somebody with an immunocompromised system. And it was like visitors with a mask, a few different things. But the answer was flowers and soil, because these can transmit disease.
Hello.
Bacteria. Hello. So just know that that was a important question. We didn't really need to know the chain of infection, but it's kind of, if you just go over page 53, it just makes sense. And if you've had micro, which you have, you'll remember all of this.
Natasha,
yes.
Can you please go over the invasive? You said the invasive, the reposition, because to be honest, I didn't pay attention.
Oh, least invasive to most invasive. So when we are, so we were talking about pain. So we as nurses, we should take least invasive measures first prior to more invasive, such as medication. So repositioning the client is like number one, try that first, because just repositioning the client can make the pain go away. We can also use music, meditation, massage, just different, touch techniques, just TV, just to kind of distract them from the pain they're going through. And then if they're still not feeling better, then we can see if the doctor wants to prescribe any medicine. And we use the IS bar in order to communicate with the doctor to see if they want to do that. Does that make sense? Okay, great. Good. Thank you. So that's all of week 1. If you guys have any other questions, or I can just go over again with the new people. And thank you, Sam. And we have a YouTube link where you guys will be able to watch this again and fast forward through the information. You don't, oh, I'm so glad, owner. And come back next week. I'll be here. So did everybody fill out the form? Then all the newcomers? And here's the YouTube channel link to just maybe save in a document. And I can go over the lecture again if you guys want, for those who came in late, or you can always listen to the YouTube. Yeah, perfect. Yes, I'll try to make it short and quick. Yeah, I know. Well, sometimes, so if the professor writes their own quizzes, do you guys know how to go onto Blackboard and re-listen to the lecture? Okay, so you go into Blackboard Collaborate, and then before joining a course room, there's like 3 little lines on the top left, and you click that, and it will say view recorded sessions. So just go over that. Usually the professors will lecture on what will be on the test. So try that, Anastasia. Okay, so we started with the vital signs, and that is heart rate, respiratory rate, blood pressure, temperature, and pain. And the heart rate is 60 to 100. The respiratory rate is 12 to 20. Blood pressure is 120 over 80. Temperature 98.6. And pain, you always want to ask if the patient is in pain. And so if the heart rate is slower than 60, we call that bradycardia. And if it's over 100, we call that tachycardia. And that is on a scale 0 to 4, 0 being absent, 1 being weak, 2 being normal, 3 is increased heart rate, and 4 is a bounding heart rate. And we assess the heart rate and pulse bilaterally usually. So like on the radial, on the pedal pulses. In your book, you'll see all the different pulse sites that we have. We have a lot. And the one area where we only assess the pulse on one side independently, not bilaterally, is the carotid artery. So right here. And you don't do that because that is the blood flow coming to your brain. And usually bilaterally, we feel the pulses for 30 seconds and multiply by 2. But if you notice there's a difference between the pulses bilaterally, we assess the apical pulse for 1 minute. And this is to see if there's any deviations from the pulse, if there's a there's a problem with the heart. And so things that can affect the heart rate, exercise and caffeine can increase the heart rate. And so we assess and you guys can interrupt me whenever. I'm just trying to go over this quickly because I know we don't have much time and I'm sure you guys have lots of things to do. So you ask the patient, have you had caffeine? Have you exercised just now? Have you ambulated? Ambulate means walking. How are you feeling? And then for temperature, we make sure that they haven't had, well, things that can alter the results is if you've eaten, drinking anything, or smoked, and usually you're supposed to wait 30 minutes before taking the temperature of the patient because it can alter the results. So just make sure that you know that if you drink hot coffee before you take the temperature might be a little higher. So the respiratory rate, it's 12 to 20. If it's less than 12, okay, hold on, somebody else is joining. I need to get the link again. Hi, Janice. We're just going over, yeah, temporally, yes. If you can fill this out, Janice, that would be great. My name's Natasha, and then I get credit for everybody being here. Thank you, Janice. Okay, so respiratory 12 to 20. If it's less than 12, yes, there's going to be a YouTube you can access later and go over this however many times. And this end, I'm doing it super fast at the beginning. It was a little slower, but I'm just gonna tell you guys what I know. Yes, of course. So bradypnea is less than 12. Tachypnea is greater than 20. So just remember, you know, tachy and brady. Knowing the root words of everything really helps. Apnea means absence of breathing, and orthopnea is difficulty breathing laying down. And dyspnea is difficulty breathing, so having difficulty breathing. So the blood pressure, anything less than 120/80 is considered normal because, I mean, people exercise and can lower their heart rate. I know that some people can meditate and lower their heart rate. So just know that less than 120/80 is normal. And then the hypertension stages, pre-hypertension is the systolic is 120 to 139, and the diastolic is 80 to 89. And the hypertension stage 1 is 140 to 159, and systolic is 90 to 99. And then hypertension stage 2 is anything over 160, and systolic anything over 100. So how I remember this easier, the diastolic, or sorry, I was mixing up the systolic and diastolic. Systolic is first. I was reading it wrong. So for the systolic, that's the first number, and that's usually, it increases by like 19. from normal. So 120 to 139. And then the diastolic increases by 9. So pre-hypertension, 120 to 139. The diastolic, 80 to 89. And then hypertension stage 1, it does it again. So pre-hypertension ended at 139. Hypertension stage 1 starts at 140 to 159. So it's 118. And then the diastolic is 90. And then anything over 160 is stage 2. Anything over 100.
Yeah, we need to start eating because we need to leave at a certain time.
I think somebody's
I'm not taking it.
Somebody's
I just woke up
not
too.
muted. Okay, so just know your blood pressure stages for sure. And then temperature, 98.6. If the quiz asks you a patient is afebrile, what should you do? But afebrile just means without fever. So it's kind of a tricky, they try to trick you on afebrile. And so pain, exercise, fever, caffeine, and illness can all increase vital signs. And so we'll go into, yes. So here, I'll type it right here. So PQRST is when the patient says they're having pain, you go through PQRST. So first you ask, are you having any pain? And the patient says yes. So then P is for provoking or precipitating factors. So you ask, what provoked this pain? What brings it on? What makes it better? What makes it worse? And then the Q is for quality. So what does it feel like? Can you describe the pain? Is it throbbing, stabbing, dull, burning? I hope you guys can still hear me.
She doesn't like my room no more.
I think somebody's unmuted. If you want to mute yourself, that would be great, so everybody can hear me. Okay. It's okay, it happens. And so the quality, so throbbing, stabbing, dull, stinging, burning. R, region or radiation. Is the lower back pain radiating down the leg? If so, it might be like sciatica, but we won't diagnose anything. Just, document the information. If it's inflamed muscle, it will only be in that specific area. And then S is the severity of the pain. So you use the pain scale 1 to 10 if they're verbal. You can also use the Wong-Baker face scale, and that's if they're nonverbal, you can see by their face, if they're grimacing, they're in more pain. If they're happy and fine or calm, then less pain. And then the infants, you use Cries scale. Hey, Janice, sorry you got, there's 2 of you. Infants, you use Cries scale. And then the FLAC scale, here. Just know infants is Cries scale. I remember that being a question. And then the FLAC scale is used for 2 months to 7 years for people that cannot communicate their pain verbally. Is the FLAC scale. And so then, okay. And then T, time and treatment. So how long has this pain lasted? Is it intermittent, only laying down, only at night? And then treatment, what are you taking? Is the medication helping if they are taking any medication? And for pain management, we were talking about the least invasive first. So distraction, music, massage, visualization. But we first want to try repositioning the client, and we reposition the client every 2 hours. And there are pain medications that are prescribed to patients by the doctor. So the ones that we went over were NSAIDs, such as Motrin and ibuprofen. But the bad thing about those, it can cause gastrointestinal upset, gastric ulcers, or bleeding ulcers. So that's a danger of those. And opioids, the danger of those is that they are narcotics, they are addictive, they can cause constipation, respiratory depression. So you want to make sure that you're always evaluating the respiratory, making sure that they're breathing okay. And if somebody says, okay, I'm having a 7 to 10, back pain, and they want morphine, just call the doctor, tell them what's going on, and you can do a hot compress, cold compress, but first always reposition. Excuse me. Okay, and then communication, therapeutic communication, IS bar, clarifying, paraphrasing, reflecting. So, okay, so yes. So that is when you're talking to a patient. So, so for you want to talk to a patient so that they don't become defensive. You want to help them as best as you can. So say like they're like, I'm so afraid that I have this illness. I don't know what to do. I have mortgage due. Then clarifying is, you can say, it seems like you're stressed out about your diagnosis. Paraphrasing, you just pretty much paraphrase, okay, so you're worried about your mortgage and a lot of different things. Reflecting is how it sounds like you are very distraught. Can you tell me about that? So you always want to ask open-ended questions. Clarifying and paraphrasing, it just kind of helps the patient feel understood. So you can see this in your own life a lot, and you know, like even communicating like with friends and family now, I try to use therapeutic communication, like if somebody's upset, and so it's like, if they're like, I'm so angry, blah, 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 it's like, well, it seems like you're really upset. Tell me about it. And then it kind of soothes them, and they can kind of explore their own feelings more. And so it's been helpful, like outside of nursing, and you know, even in relationships, it's like if your significant other is upset about something, like, oh, it seems like you're really stressed out, and then they just go on and kind of just vent, and then they're over it. So thanks for asking about that, because I know it's confusing, but just look for the question that's most like open-ended or reflecting what you said, or paraphrasing, summarizing what they're concerned about. So I was doing practice questions. Reflecting technique is more based on the feeling of the patient. So, okay, yeah. So you're feeling, it seems like you're feeling stressed out. Paraphrasing is pretty much summarizing and repeating what they said to you, just to make sure that they know that you're listening and they're heard. And then reflecting is how can they reflect on their emotions, and how can you ask an open-ended question for them to reflect on their feelings. It takes some practice. Practice questions definitely help with these communication techniques, but usually with the test questions, it just asks what would be the best response for the patient. It's usually, they could ask specifically, but they just want you to know therapeutic communication. And so doing questions that are like, what's the best response for this scenario? Just look at all of them and think, what's the most open-ended, helpful, something that's not making the patient defensive. There are communication modules in ATI, and it's called the communicator, and those help with such scenarios, interacting with family and patients. So I think it's under Apply, under ATI, and it's like Communicator 3.0, and you can go and it's like a little video, and then you do different responses, and it tells you what would be the best response. So I would suggest doing that, because then, I'm a visual learner, so it helps me see the videos, see the scenarios, since we aren't in the hospital right now, or I don't think you guys are in the hospital right now. And so, okay, perfect. And so really just, you'll be assigned those later on, I'm sure, but just doing them now, you'll be ahead of the game. And so, is that clear for patient communication for everybody? Okay, perfect. I'm glad. And then, so for the IS bar is for communicating with the doctor or with other nurses when you're handing off a patient. And so IS bar, introduction, situation, background, assessment, and recommendation. So introduction, my name's Natasha. I'm caring for Mr. John Doe. He's in this ward, unit, whatever. And then the patient's name, so John Doe, he's 72, male. The admitting doctor was Dr. Smith. And the situation, so if you're handing off the patient, you just tell them what's happening now. Mr. Doe is throwing up and having diarrhea for the past 2 hours intermittently, 15 minutes intermittently. And if you're on the phone, you say, I'm calling about Mr. Doe. He has been throwing up and having diarrhea intermittently for the past 2 hours, every 15 minutes. And then the background, you talk about the patient's past or why they came in. He came in with stomach pain, and he's allergic to this medicine, or he doesn't have allergies, he has a history of hypertension and falls in the past, his vital sign, and then assessment is A. So his vital signs are normal, but he reports a pain scale of 8 out of 10, and I've witnessed, or I've seen him going to the bathroom every 15 minutes to vomit, or he has diarrhea. And then R is for recommendation. So if you're calling the doctor, it's like, would you recommend, you know, more fluids? Would you recommend holding fluids? Would you recommend medication for his nausea or vomiting? Would you recommend any interventions that a doctor needs to approve of in order to intervene? Not just a cold compress, repositioning, we can do that ourselves. But for like medication, we need doctor's approval. And then when you're handing off the patient to somebody else, you can say, I recommend, you know, check on him every 15 minutes. The doctor prescribed this. I just gave it to him 5 minutes ago. It's prescribed every hour, and just let them know what's going on. So IS bar is a good thing to practice. You can practice, you know, with yourself, with your dog, whoever. And just make stuff up like I just did. It's once you just do it, it's easier, and they'll ask you to do it a lot in the future. So just knowing how to do it is really helpful. When a patient cannot pronounce words, that's called dysphagia. And I know dysphagia is you can't swallow, so dysphagia is just the words don't make sense. And if the patient speaks a different language, you need a certified translator. And you cannot have the family translate for the patient. You can't translate yourself. You have to make sure that you have a certified translator to translate. And when you're using the translator, speak to the patient, face the patient. You don't want to speak to the translator because it's like you're ignoring the patient. So the patient always comes first. Just try to do what's best for them. And, you know, you'll know what's best for them when you're in this scenario. And, you know, if we all want to be good nurses, so it's like, okay, patient is our priority. So then we talked about infection control. So the most important thing to prevent infection is hand hygiene. So we can use soap and water for hand hygiene, or we can gel in and gel out. And you practice hand hygiene before and after seeing the patient. You use gloves whenever you're touching the patient. And if your hands are visibly soiled with bodily fluids such as blood, urine, sputum, ear drainage, when patients have C. diff, remember this, C. diff, you always use soap and water because there's a stool transmission that can get onto your hands. And so you use warm water, 4 to 5 milliliters. And milliliters, they'll use the term milliliters and cc's, and those are interchangeable. They mean that they're equivalent. So 1 milliliter equals 1 cc. So 4 to 5 milliliters or 4 to 5 cc's. And that's of soap. So it's like the size of a quarter. And you lather up, sing happy birthday twice, 15 to 20 seconds for soap and water, and you get your nails, your fingers, your wrists. And when you rinse, you put your hands downward and use a paper towel, dry hands, and turn handle off. And when your hands aren't visibly soiled, use hand sanitizer. And so the PPE, you want to always have a mask on. Always have a mask on when you're seeing a patient, and gloves when you're interacting with the patient. But if you're using the all of the equipment, when you put on the equipment, you first do the gown, and then the mask, and then goggles or a face shield. And lastly, you put on the gloves, and that's when you're going in. And when you're coming out, you take off the gloves first, and you do, glove to glove and your skin to skin. So you don't touch the glove to your skin, you touch the glove to your glove and your skin to your skin. So your gloves first, and then your gown, then your goggles, and lastly your mask. And well, you usually do it that way. And then hand hygiene always when you're done. And sometimes you will be shown videos that have gloves and gown at the same time, but just know that for ATI test questions, gloves come off first. So HAIs or nosocomial infections are the infections that patients can get while in the hospital. And so that's why we have these different PPE precautions. So contact precautions, here's some contact precautions that are good to remember. So C. diff, impetigo, herpes, encephalitis, I just put incef, tygo, hepae, lice, scabies, or dermatological contagious infections, dermatological. And then for that, you want to use a gown, gloves, and a mask. And droplet is a particle greater than 5 micrograms, and so it drops quicker due to gravity, unlike airborne precautions. So with droplet, you want to wear your mask, gloves. It depends. Glasses are good, or a face mask is good, and gown. If people are visibly soiled, you always want to use all of the PPE because you don't know what can transfer, and you don't want to get all this stuff on you. Okay, and then airborne is less than 5 micrograms, and that is airborne is tuberculosis, varicella, and also COVID is droplet, just to let you know, FYI. And then airborne, you want to use an N95 mask because the particles are smaller and they can travel further, and you can get the infection if you don't have the N95 or filtered mask. So, and then you always want to have the mask on the patient if you're transporting them from a room or to like radiology or somewhere. Always have the mask on the patient. And that, we went so fast for that. Oh, our goggles used for airborne. Let me double check. This one, it always confuses me, but so airborne. So N95, and then the room is negative pressure. So this is on page 56 of your ATI book. Negative pressure, airflow exchange in the room for airborne. And if they're splashing or spraying, wear a full face, eyes, nose, mouth protection. And the clients who have the airborne should wear a mask while outside of the room or the home. Then droplet, you can have a private room or a room with other clients who have the same infectious disease, but make sure the clients have their own equipment, provide masks for visitors, and they should wear a mask if outside the room. And then the contact, private room, and they can also share a room with people with the same infection, but with different equipment, you know, like equipment for each of the patients. And gloves and gowns are worn by the caregivers and visitors. And you dispose the dressing material into a single non-porous bag without touching the outside of the bag. So I remember that being a question on ATI is how to like remove, or like if you have a soiled bed from somebody with C. diff, what do you do? And you put it in the non-porous bag. You don't just like fold it up and carry it around. You want to fold it so it doesn't get on anything else, and then put it in the bag. And yeah, so just, and then the immunocompromised. So those are people that have had a transplant, they have had chemotherapy, they have HIV or something. So they need a private room with positive airflow, and the mask needs to be for the client when they come out of the room. And there was, I remember a question about what's not allowed or for somebody with immunocompromised system, and the choices were like visitors, wearing masks, a few other ones, but the answer was potted flowers, because the soil and the flowers can transmit bacteria, and you don't know what's in the soil to the immunocompromised. So that was a tricky question, but I'm glad to tell you guys, so you guys know that, you know, you don't want to have potted flowers or plants for people with compromised immune systems. And yeah, so I think that covers all of my notes from the first lecture. And I don't know if you guys have, do you guys have your first quiz this week, or have you had it yet? Anybody have class Monday? I don't know if they have class Monday. Okay, tomorrow. Well, I highly suggest the NCLEX workshops as well. He goes over questions, ATI questions, and he gives special ATI codes, so you can take practice tests for like 20 questions per practice test, 15 to 20. And they really help, and they explain the reasoning. don't be nervous. I mean, depends on the professor, usually 20 to 25. Yeah, 25. So, and you're allowed usually a minute and a half per question. I had Day Salinas, but she is out for this term. But I know that people were switched to different classes. Yeah, so she was great, but you know, all of the professors are great, and just read your ATI, practice your ATI, do the communicator. That will help a lot for the therapeutic communication. And after reading your ATI, like in the back, there's questions, and in the back of your book too, like each chapter, there's questions. And so, and go to Bernie. I think Bernie's the one who does the NCLEX. He was so great. I went to him every week. And so it depends on the teacher how the questions are. So just go and re-listen to the lecture if you can, because usually the teachers will lecture on what will be on the quiz, from my experience.
Natasha, I have a question.
Yeah.
So I got this wrong on my ATI book. They have like little questions at the end of the chapter.
Mm-hmm.
And the question is, a nurse is collecting data from a client who's reporting pain despite taking, I don't know if I'm going to say this right, analgesia?
Yeah.
Which of the following actions should the nurse take to determine the intensity of the client pain? So it's A, ask the client what precipitates the pain. B, which is what I answered, is question the client about the location of the pain. C, offer a client a pain scale to measure their pain. Or D, use open-ended questions to identify the client's pain.
So great question. You have to go on whatever the client says their pain level is. So it's always using the pain scale. So,
okay.
so whenever, like, that's your most accurate measurement of the patient's pain is their own report. And, you know, and like, I had to get used to, okay, you know, like, it's not what I think at all. It's what the patient thinks.
Mm-hmm.
We're working for the patient. So if they're telling us it's a 9, we got to take it as a 9 and report it as that. And then hopefully we can get it down lower. But that's the most reliable, and they'll ask a question about this, guaranteed, is what is the most reliable assessment for pain. It's whatever the patient tells you.
Okay, so always a pain scale.
Yeah, the pain scale for what the patient tells you. Because I know that you said like the first one was like if it's radiating or whatever, but
no, what I thought it was is question the client about where the pain is, like the location. That's what I thought it was, but it was wrong.
Yeah, and so was the right one the pain scale?
That was the correct one.
Yeah, so always the pain scale is the most accurate, and verbal or, you know, cries for infants or whatever pain scale is the most accurate is whatever the patient.
Awesome.
And then so the apical pulse rate, no, I was saying the carotid. So here. So that you do the apical pulse for a minute if the bilateral pulse is off at all. So like if you're assessing the radial pulses and like you notice that they're off, then you'll assess the apical pulse for 1 full minute and see that rate. And then but the carotid artery, you do not assess that bilaterally. That is just with one arm, 2 fingers, 1 arm, and or 1 hand. And because if you do 2, it will mess up the blood flow to the brain. Does that make sense, Karen? Okay, perfect. Yeah, of course, of course. And I hope you guys come next week. I tutored Patho last term, but I'm excited to tutor funds because I really enjoyed it and it really got me into it. It's perfect for starting out nursing, and you learn so much, and you learn, you know, it's not just about facts, it's about helping the patient and what to do. Yay, perfect, Janice, I can't wait. And yeah, so I'll be here every Tuesday, it's Tuesday today, every Tuesday, 9:45 to 11:45. And definitely go to Bernie. ATI codes really help. Just ATI book, I mean, every chapter is only a few pages, so you guys can definitely do that. And read the book if you can. And you'll see how your teacher likes to test, if it's more lecture-based, if it's more ATI. The first quiz is always, you know, you kind of have to figure it out. But definitely listen to the lectures and yeah, re-listen to the lecture. Even if you're like going to bed, put on the lecture and go to sleep, like just listening to your teacher, because you'll remember stuff. It works for me. So if anybody has any other questions, we have like 5-6 more minutes. So let me know. If not, I'll see you next week, hopefully. And oh yeah, the YouTube link. Let me get it. 1 second. And you guys can listen to, okay, listen to this again whenever you want to hear my voice. Okay, there you go. There's the YouTube link. Thank you so much, Rima. See you next week. And thank you everybody else. And yeah, listen to the YouTube. You don't have to sign out. Just make sure you sign in so I get credit. And yeah, best of luck on your test, you guys. You'll do great. You got it. And any other questions? I'm here for 5 more minutes. And oh, I'm so glad. I'm so glad it helped being a tutor last term. Now I know, you know, the flow of things and how to do it. So thank you. Thank you. Thanks for coming. Bye. Bye, Anastasia. Bye, Karen. Carl and okay, Luis, you have any questions? Last one. I'm here for 4 more minutes, so if anybody, Luis, if you have any questions, I'm here. All right, I'll see you next week. And thank you for coming. Okay, now it's just me. Well, I hope everybody enjoyed the lecture and learned something, and I'll be here every Tuesday, 9:45 to 11:45, and I don't know if you guys can see the chat. Oh, well, you have to access the YouTube to see the chat, but there's the YouTube link, just in case. And good luck, everybody. You'll do great. This just reviewing helps. It helped me so much last term. I went to PALS as much as I could, and it just helps get the information in your head. So yeah, so thanks for coming, and I will see you guys next week, hopefully. I guess I have to unmute myself. I'll just do a video for 1 more minute. So first week down, second week, we got this. Flies by, the 10 weeks fly by. That's for sure. So keep up on your reading, you guys. And every NCLEX, PALS, whatever you can do it. If you have the time, do it. And I'll be here next week. Okay, it's 11:45. Thank you for everybody who came today, and the YouTube is up, and I will see you guys next week. Okay, bye.